Sir, shall we start?
Yeah, I think we should start at 7 o'clock sharp.
Okay, sir. Thank you.
Sir, just allow me
Uh,
10 seconds, sir. I'll give you the countdown.
okay.
Sir, we are going live in 3, 2, 1. You may start now, sir.
Thank you. Good evening, everyone. A very warm welcome to Blood the Life Savior, a platform where the clinical insight meet real world learning, and where every case discussed add to your collective experience. Today is our 15th episode. We are privileged to collaborate with King George Medical University, Lucknow, an institute renowned for its academic excellence and clinical rigor in the field of hematology. We have two exceptional, interesting, and the challenging case lined up, highlighting the complexity and the ever-evolving the nature of hematology and hematological disorders. It's now my distinct honor to introduce the two pillar of our series, our distinguished course director. Before we begin, I would like to extend a special and heartiest congratulations to Dr. Biju George sir on his appointment as a director of CMC Vellore. Sir, your leadership is an inspiration to the entire medical community, and we are incredibly proud of this achievement. Dr. B. George, he is the director and professor, Department of Clinical Hematology, CMC Vellore, and sir is having experience of more than 17 years in hematology as a professor. And further to this, he is a vice chair of the Asia, Africa, Australia Advisory Committee of the CIB MTR. Sir is the author of over 296 publications, and Sir has developed the national standard conditioning protocol of aplastic anemia and pioneered over 200 haploidentical transplants at CMC Vellore. Further to this, our second distinguished course director, Dr. Joseph Jones, sir, he is the professor and head of the Department of Clinical Hematology, CMC, Ludhiana. Sir is the associate director of the Development and Quality and NABH at CMC, Ludhiana. Sir is the recipient of ICMR NIIH Orientation Award and SKOCH Gold Prize with over 60 publications in his credit. Sir is the instrumental in establishing a stem cell transplantation service at CMC Ludhiana and launching the India's first DM program in clinical hematology. Under their supervision and leadership of our course director, the Life Savior continue to be an enriched platform, fostering medical education and collaborating the learning across institutions. Now I'll request Biju sir to take over the session and lead us with today's presentation. Over to you, sir.
Thank you so much. Welcome everybody to this 15th episode of Blood the Life Savior. So today we have doctors from King George Medical University going to be talking about two different diseases. One is looking at emergence of CML in a patient with chronic ITP, and two is a case of congenital sideroblastic anemia presenting with pancytopenia. Because they are two separate cases, what I thought we should do is we'll do the presentation of the first case, discussion, and then we will open up for questions related to the first case. And once that is done, we will move forward to the second case. So over to you. Is SP Verma here?
Sir,
Yes,
he is
sir,
there,
I'm
sir.
there.
Sir is there, sir.
Hi, Dr. SP Verma. So if you could just introduce your colleagues and then we will start with the first case presentation.
Yes, sir. So, good evening, everyone, and thanks for this opportunity. Today we have Dr. P. Raghuveer. He is assistant professor in the Department of Hematology, and he will be just moderating the session. And we have two presenters. Both are our second year DM clinical hematology students, Dr. Aritra Saha and Dr. Raj Kumar. So, I would request Dr. Aritra to start with the first presentation.
Yes, sir. Uh, a very good evening, respected teachers and the members
Sorry,
of the
sir, to
organizing team.
Can you put it on full screen mode?
Yes, sir. Now it is on full screen, sir. Yeah.
Is
Uh,
it visible, sir?
Actually, you have not shared your slide. You have shared the screen itself. So if you share your slide, so the slides will come only, not your picture.
No,
You
We'll
just
just
share
check
the
it.
slide. Sport team, can you help?
sure, sir. Sir,
Is
you
it
have to turn off the picture in picture mode.
is it okay?
better now?
Yeah,
Yeah,
now it's
now
done.
it's okay.
Yeah.
Yeah.
Yeah. Respected faculties and the members of the organizing team, very good evening to all of you. I'm Dr. Itra, Senior Resident in the Department of Clinical Hematology at KJMU, and I'll be discussing a rather interesting case of a patient who had chronic ITP and later on she develops CML. So coming to the first presentation, yes. So back in 2012, a 30-year-old lady presented to us with severe menorrhagia associated with occasional purpura and generalized weakness. She was vegetarian by diet. She had a history of multiple transfusions at a regional hospital. However, this presentation was not associated with any B symptoms. She had no history of any addictions or prior comorbidities, and there was no family history of bleeding or any malignant disorders. So when we examined the patient, there was pallor, petechial spots were there, that was kind of generalized, and cheilitis was noted. However, there was no hepatosplenomegaly or lymphadenopathy on examination. So when we investigated the patient, we found that patient had a severe anemia, as you can see, hemoglobin of 3.8 gram per deciliter, and a severe thrombocytopenia with a platelet count of only 5,000. And the TLC was slightly on the higher side. So when we looked at the peripheral smear, we found that the RBCs had a microcytic hypochromic picture, and the WBCs did not comprise of any abnormal cells. It was mostly a neutrophilic leukocytosis kind of picture. There was no apparent left shift, nor there was any atypical cells, or nor there were any basophils at that time. Nutritionally, patient appeared to have iron deficiency. As you can see, the ferritin was on the lower side. However, B12 and folic acid were okay. That did not require any intervention. Later, when we saw the LDH, it was quite raised. It was 860. The upper normal limit was 480. LFT and liver function and renal function was normal. However, the viral etiologies, autoimmune etiologies, Coombs, these were all negative. And when we did a bone marrow aspiration, it was essentially normal with slightly increased megakaryocytes. As you can see in this picture, we can see that the multiple megakaryocytes are noted, but obviously there was no any atypical cells, and essentially it was normal picture. So our treatment composed of these are the four lines, which I'll be discussing elaborately in the subsequent slides. So the first line was obviously steroid. We initially administered methylpred pulse therapy followed by oral prednisolone. In the second line, we used L-Trombopac. Third line, splenectomy, and the fourth line was rituximab along with dexamethasone. So when the patient presented to us, we administered 3 days course of methylprednisolone pulse therapy at 1 gram per day. And after that, she was started on oral prednisolone at the dose of 1 milligram per kg per day. She was steroid responsive. But the issue was when the steroid tapering was started, she started to lose the response. So in the second line, we used L-Trombopac. So L-Trombopac was started at a dose of 50 milligram per day, and she again did achieve a complete response. But the issue was that back in 2014, the Eltrombopag used to cost somewhere between 45 to 50,000. So it was not possible for them financially to continue this drug. So we had to attempt to taper the drug. And when we attempted to taper the drug, there is again a loss of response. And then we had to make a decision to whether to go for rituximab-based therapy or splenectomy. Patient was given both the options. And considering that splenectomy was a one-time thing, one-time procedure, and at that time splenectomy was quite commonly being done as a third line setting. So patient opted for splenectomy. Uh, After the splenectomy, there was a modest response, but again, at the end of 1 year, she had again started to develop bleeding manifestation as severe thrombocytopenia. So, as a fourth-line therapy, lastly, we used rituximab-based therapy along with rituximab and dexamethasone. And fortunately, she responded to it. After 6 weeks of the fourth dose of rituximab, she did start to show response, and eventually, she attained a complete response. She enjoyed being in complete response for a period of 3 years, and later on, she was lost to follow. So now coming to the second presentation. So now that same lady is now 39 years old. She was lost to follow for 4 years. She presented in 2021 with fatigue. Again, it was not associated with any B symptoms, and on examination, there was no significant findings. So when we investigated the patient, this time the hemoglobin was normal, platelet was normal, but this time the TLC was very high. It was 2.3 lakh. On peripheral smear examination, it revealed the RBCs are normocytic normochromic, but the WBC showed significant shift to left with 4% myeloblast. So we suspected that she might have developed CML in chronic phase. We did a BCR-ABL, which showed 38.611%. Considering the case was a bit interesting because it is not common to have patients with ITP develop CML, we did a clinical exome sequencing to look for any somatic or germline mutation that could have predisposed her to develop CML. So when we did this clinical exome sequences, we found two variants of unknown significance. One was Adam TS13, which we know is associated with TTP, and the other was GATA2. Both were heterozygous mutations and were variants of unknown significance. At that point of time, it was not possible on our end and on the patient's end to get the same testing done in the family members. So we could not investigate it further. And on the left-hand side, you can see the peripheral smear picture of the same patient once she had developed CML. We can note that there are multiple myelocytes, metamyelocytes, and segmented neutrophils and band forms are noted. So once the patient developed CML, at that point of time, the only issue was the hyperleukocytosis, the 2.3 lakh count, whereas hemoglobin and platelet count was normal. So we started the patient on dasatinib at a dose of 50 milligram per day. But after around 4 months, initially she did develop a thrombocytopenia, but it was not significant enough that we had to stop the treatment. But after 4 months, she developed significant thrombocytopenia with generalized PTK that corresponded to WHO bleeding rate 2. So as a result, we had to stop dasatinib temporarily. And we did the bone marrow examination again, which did not reveal any other source or any other etiology for the possible bleeding. And we had to think that this is possibly because of the ITP. So as a result, because she had previously responded to rituximab and dexamethasone back in 2014, we gave her a second course of the same drug. And again, fortunately, she did respond to that. And after she achieved a response, once the platelet counts were normal, we started her on imatinib. And we did not start this dasatinib in view that it could cause more cytopenias. And when we added imatinib, and to balance that, we did add romiplastim at a dose of 125 microgram per week subcutaneously, and it was continued and it was gradually tapered and stopped. So as you can see here in this picture, so once the diagnosis of CML was established, we started her on dasatinib, but as she developed severe thrombocytopenia and symptomatic with ITP, we had to stop the dasatinib. We started her treatment on the lines of ITP with rituximab and dexamethasone. And with that, she again achieved a complete response. And once she achieved a complete response, we started her imatinib but did not start dasatinib again. Along with, we did give romiplastim until a response was achieved. And once she achieved a complete response, we gradually tapered romiplastim and stopped it. And once she was maintaining that, and now she's doing well. So this is the complete picture. As you can see, the blue line represents the total leukocyte count, the green line represents the platelet count, and the red line on the right-hand side represents the BCR-ABL quantitative PCR, and it highlights the entire picture of the decade. So this is her latest follow-up. She was seen by us on 16th of January. Now she is maintaining a hemoglobin of 12.5, total count of 5,400, and a platelet count of 1.3 lakh. Her last BCR-ABL was done in September, which was not detected suggestive of deep molecular response. So currently she is enjoying a deep molecular response with respect to CML and a complete response with respect to ITP. In our last follow-up, we reduced the dose of imatinib to 200 milligram per day. We did offer her the option of TFR, but she was kind of reluctant and worried that so we reduce the dose to 200 milligram per day, and she's tolerating the drug well. So ITP and CML, is there any link between the two? So we know that ITP is an autoimmune disease, and it involves the immune-mediated platelet destruction and may present with various kinds of bleed. Any autoimmune conditions, including ITP, have a, because of the chronic immune dysregulation, there is a inherent risk for developing malignancies. So chronic ITP patients also have a 1.45 incidence rate ratio for secondary malignancies compared to general populations. And among those malignancies, the most common are the hematological malignancy, and out of them, Hodgkin's lymphoma, non-Hodgkin's lymphoma are more common. So the occurrence of the two diseases together is very rare, and to the best of our knowledge, this is only the sixth case which has been reported to have developed CML in a patient who had ITP. You can see there are other five cases. Of them, uh, two of them achieved a complete response, achieved a molecular response. However, three of them succumbed to the disease. The first case, as you can see, was a 49-year-old male. The gap was 15 years between the CML and ITP. First line treatment was corticosteroid, second was eltrombopag. And after he was started on imatinib, he achieved a complete molecular response. The second case was an elderly male. Again, the duration of the gap was quite small, 1 year, 7 months. The first line again was corticosteroid, second was eltrombopag. He was started on dasatinib, but eventually the patient developed blast crisis and succumbed to the disease. The third case described by Imashukwe et al. Was a very young child, 3 years old. The duration, no, that is the age of diagnosis for ITP. And the gap was 29 years. She was started on corticosteroids at the second line IVIG and third line splenectomy. She enjoyed a complete molecular response at 12 weeks. The other cases, one was not completely described, but we got to know that it was described as a part of a series where they mentioned that the patient, after 7 years, developed CML and eventually died because of meningococcal meningitis. And the last case was where the patient developed CML and soon after transformed into AML and also succumbed to the disease. So the key takeaways that I would say are that vigilance is important because of the risk of long-term neoplastic transformation. So it is important that we maintain a high index of suspicion for secondary hematological malignancies in patients with chronic ITP. And it is important that we select TKIs wisely because we know that dasatinib is notorious for causing cytopenia. So maybe uh, we can choose drugs that are less commonly associated with cytopenias like imatinib or nilotinib may be a better agent. And when these two diseases occur together, treating only one of them is not good enough. So we may require to treat both the diseases simultaneously. Like in this case, we treated the patient with both imatinib and romiplastin. And it's very important that we do a longitudinal monitoring, cautious dose titration, so that we can abruptly stopping the drug may lead to a loss of response, which we have also seen in managing aplastic edema patients. So it is important that we gradually taper the dose and keep the patient on follow. So that would be all from my side. Thank you.
Thank you so much, Dr. Ritra. Very interesting case. I know there have been uh, descriptions of the association of CML with pure aplasia, but this association with ITP, like you mentioned, there are very few cases, and it is. So, one of the questions I think people always would think is, could the splenectomy have led to uh, progression, whether there was a, because if I'm not mistaken, at the time of diagnosis of ITP, the WBC count was high. It
Yes, sir.
was about 25,000, I think.
Yes, sir. Correct, sir.
So whether there was there, and at that time I assume that you did not check for BCR ABL because the marrow wasn't like any myeloproliferative disorder at all.
Yes, sir.
So the question would be, at that time, was there also a BCR ABL there? And then whether this sort of stimulated that to move forward is something I would always keep at the back of our mind. But this very, very interesting case.
So, sir, just wanted to put one point. So, that time the patient presented with severe menorrhagia and severe anemia, and that time there was severe thrombocytopenia. So, we thought maybe it was a stress-related leukocytosis because there was no shift at all.
Sure.
And when we started the treatment, and during so many years on treatment of ITP. She never had any evidence of high counts or progression, which is very less likely if you are not giving a CML directed treatment. So probably that was the reason we didn't go for any further.
So during those 4 years of treatment, the WBC counts actually settled down.
Settled down. It was
Yes,
normal.
yes,
So
sir.
probably it
Okay,
was.
okay. So that is a bit unusual. Yeah. Are there any questions? Please put it either into the chat or Q&A. So the other question I would like to ask is going into literature. So we know that if you have ITP, it predisposes commonly into malignancies which sort of affect the lymphoid lineage.
Yeah.
So you can get Hodgkin's lymphoma, you can get non-Hodgkin's, other diseases. How common is diseases of the myeloid lineage common in somebody with ITP?
So, sir, from
Yeah,
yes, so from the Swedish registry that we saw, like you said, sir, very correctly, most of the patients that developed malignancies belong to the lymphoma group. So there were only a handful of cases that developed myeloid malignancies, and as a whole, the incidence of this hematological malignancies, the risk increases by 9%. So although I cannot quote the exact percentage of the myeloid malignancies, but I'm assuming that it is somewhere less than two, it's very handful. I won't be able to quote the exact incidence of myeloid malignancies because it's too less, sir.
sure. And this patient has sort of got into a major molecular response now on
Yes,
imatinib?
sir. Yes, sir. Yes, sir. Yes, sir. So she has been in deep molecular response for the past 4 years, sir.
Okay, okay.
So, sir, in this case, actually, the first possibility we thought is there is a total disconnect. Probably there are two entities, one developed at one particular time, and the other entity came out after so many years. And the other thought was whether there is any, genetic predisposition because a patient with ITP or thrombocytopenia per se developing a myeloid malignancy later on. So, considering that, we went for this NGS analysis, but we could not find the mutations which are basically associated with thrombocytopenia and then development of myeloid malignancy. It was the mutation GATA2, which is itself is mostly present when the patient present with the myeloid malignancies, and the other history of other myeloid malignancy in other family members. But
Sure.
here, even the family members, none of them had any history of any solid or hematological malignancy or any other hematological disorder. Probably that was the reason we didn't push much for looking at these mutation in family members, although patient also denied for that because of the financial constraints.
Sure, sure, sure.
Also, sir,
So,
like because the patient
yeah,
had a very good response with the steroids and all the immunosuppressive therapy that we administered, so we thought that the diagnosis of ITP was very likely, considering she had a very good response to steroids. So we did not consider the possibility of congenital thrombocytopenia syndromes at that point of time.
sure, sure. Okay, I don't think there are any questions, so we can go on to the second one. So before that, I would say, Aritra, your AI generated slides are fantastic. Those
Thank you, sir.
diagrams are really great. Tell you, it's so clear in that what you do. I mean, it describes the entire course of the patient beautifully on that. So
Thank
congrats.
you, sir. Thank you, sir.
So we'll now move on to the second case. Dr. Raghuveer, please go ahead.
Uh, Hello, sir. Dr. Rajkumar will be presenting the second case.
So please go ahead, Dr. Rajkumar.
Good evening, faculty members and entire team. Thank you for giving me this opportunity. I'm Dr. Rajkumar, senior resident in the Department of Clinical Hematology. I will be presenting a case of congenital sideroblastic anemia, presenting as a pancytopenia. Our case, a 27-year male resident of Gorakhpur presented to us with the chief complaints of progressive fatigue and pallor from last 4 months and a recent worsening of anemia requiring multiple PRBC transfusions. And in history of present illness, he had long history of anemia since childhood and with documented splenomegaly since last 7 years. And he persistently had low hemoglobin levels and oral hematinics. He was already taking over-the-counter oral hematinics, but never transfused earlier before last 4 months. And there was no history of jaundice, dark color of urine, bleeding tendency, or any recurrent infection, or no any history of hemorrhoid or fissure. Uh, and there was no constitutional symptoms also like fever, weight loss, and night sweats. In last 4 months, there was an increasing weakness, exertional dyspnea, and reduced exercise tolerance, intolerance. This leads to the because of severe anemia. In past medical history, he had anemia since 2 years of age, but he was never fully evaluated, and there was no prior transfusion until the last 4 months, and there was no history of any chronic liver disease, tuberculosis, or any autoimmune disorders. And he is a mixed diet, has mixed dietary habit, and previously he was on hematinics, and there was no history of any anti-tubercular drug, alcohol abuse, or no exposure to any heavy metals or toxins. And family history, he was born to a non-consanguineous marriage, and he is a second child in the family, and his elder sibling is healthy, and there was no history of any blood-related disorder in his younger sibling, elder sibling, and there no family history of anemia, thalassemia, or liver disease. In he has completed his graduation and he was employed in the private firm, and he had normal developmental milestone. He was a non-smoker, non-alcoholic, and there was no occupational exposure of any heavy metals or chemicals. On physical examinations, at the time of admission, patient was afebrile. His pulse rates were 90 beats per minute, regular, synchronic, and hypervolumic, and there was no radioradial or no radiofemoral delay. And blood pressure was 112 by 64 mm FSG in right arm supine position, and respiratory rate was 20 abdominothoracic. And in general examination, patient was conscious oriented. It was thin built. He had severe pallor at that time, and there was no jaundice, cyanosis, clubbing, or edema. There were no petechiae or ecchymosis, and no any signs of lymphadenopathy. And on systemic examination, there was a massive splenomegaly, which was palpable up to right iliac fossa, and there was no other organomegaly, and abdomen was soft and non-tender, and rest other systemic examination were unremarkable except for the flow murmurs, which were because of severe anemia. Based on these physical finding, our differentials were either thalassemia intermedia, HBE beta thalassemia, or alpha thalassemia, HBH disease, or sideroblastic anemia, and congenital dyserythropoietic anemia. These were the our differentials before proceeding further. On laboratory examination, we had hemoglobin of he had 5.7 gram per DL, and WBC of 1700, and platelet of 80,000, and reticulocyte count was 2.5% with MCV of 88 femtoliter, and GB blood picture was normocytic normochromic mixed with microcytes, and LDH were normal, and bilirubin was 1.4 milligram per day. These Coombs were negative, G6PD was negative, osmotic fragility test was also done, which was also negative. Iron studies were done, which showed high ferritin level and high transparent saturation suggestive of iron overload. Then we perform further investigations like EBV, CMV, Parvo were negative. RK39 was also done, which was also negative, and PNH was also negative. HPLC was suggestive of normal adult hemoglobin, and serum copper level was also normal, and liver fibroscan was also done to rule out CLD, which shows F3 grade fibrosis, and upper GI endoscopy was suggestive of mild portal hypertensive gastropathy. Further, we performed bone marrow, in bone marrow was slightly hypercellular with normoblastic erythroid precursor, and granulocytes lineage were also normal, and megakaryocytes were adequate. And further, Pearl's stain was suggestive of 80% of rim scleroblast. And karyotyping was also performed, which showed translocation 514. And we performed NGS, which showed LAS2 gene mutation on exon 9, which was hemizygous for and pathogenic for X-linked recessive sideroblastic anemia. And further, on treatment, patient was started on pyridoxine and iron chelation therapy. And after 3 months of treatment, hemoglobin was raised to 12 gram per dl, and total count was 6,750, and platelet 1,70,000, and spleen size was reduced to 3 centimeter from below castor margin from right iliac fossa. And but the patient lost follow-up and stopped treatment, and after 10 months of loss to follow-up, he again presented to us with a hemoglobin level of 7.6 gram per dl and WBC of 10,000, and platelet count was normal, but spleen was further increased from 3 centimeter to further 7 centimeter. And so, sideroblastic anemia that can be acquired or inherited, or although congenital sideroblastic anemia is rare, and they have mainly three types of inheritance. That is, one is X-linked sideroblastic anemia, autosomal recessive sideroblastic anemia, and maternally inherited sideroblastic anemia. Although acquired forms are more common as compared to congenital form, and the acquired forms can be myelodysplastic syndrome, heavy metal poisoning like lead and arsenic, and zinc overdose, which are commonly present in the over-the-counter multivitamin supplementations, and copper deficiency can also lead to the sideroblastic anemia. And B6 deficiency and alcohol abuse is also a cause of sideroblastic anemia, and our patient responded to B6 vitamin B6 supplementation. And the drugs that interfere the heme biosynthesis like isoniazid, chloramphenicol, and linezolid are also a cause of sideroblastic anemia. So in sideroblastic anemia, there is a defective iron sulfur cluster formation, which leads to the impaired mitochondrial cytosolic protein synthesis, and which leads to the further decrease iron utilization, and iron is not incorporated into the protoporphyrin 9, and this further leads to the mitochondrial iron accumulation and formation of ring sideroblast. And this reduced heme synthesis and erythroid maturation arrest occurs because of this formation, ineffective erythropoiesis occurs, and this leads to the sideroblastic anemia. So in sideroblastic anemia which can be microcytic, normocytic, or even microcytic anemia can present on general blood picture. And RBC tend to adopt low hemoglobin by decreasing their MCV. And MCHC concentration, MCHC is well preserved, and their oxygen carrying capacity is also well preserved. So that's why these patients are not that much asymptomatic than other patients. Peripheral blood smear can show basophilic stippling due to aggregates of ribosomal RNA and mitochondrial remnants in the RBCs, while macrocytic cells and reticulocytes generally contain the relatively adequate amount of hemoglobin as compared to the other RBCs. So the congenital sideroblastic anemia is further classified as syndromic and non-syndromic form. And in syndromic form, otherwise also X-linked sideroblastic anemia is the most common form of congenital sideroblastic anemia, which accounts for about approximately 40% of the all congenital sideroblastic anemia cases. It was first described in 1945 by Cooley's, and around 200 cases has been reported worldwide. And age and sex distribution, if we see, that 2/3 of the patients are male and typically present in their childhood or early adolescent age. And one third the patient are in young middle-aged females. And the females typically are carrier, but these females can present later on due to skewed X chromosome inactivation. So that's why in females the presentation can be delayed, and sometimes in females presentation can be severe also. And in causative gene, most common is LH2 gene, which is located on the chromosome X chromosome, which encodes the delta aminolevulinic acid synthetase, which is the first and rate limiting enzyme in heme biosynthesis in erythroid cells. And there is a partial loss. If there is a partial loss of function, then decrease heme synthesis and accumulation of iron loaded uh, in the mitochondria. This leads to the formation of ring sideroblast. And there are more than 80 LH2 mutations have been reported. Most commonly are the missense mutation, and some are nonsense or frameshift mutation. And these mutations affect the catalytic domain of the enzyme, are either paradoxal phosphate binding site or promoter or enhancer region or mitochondrial targeting sequences. And the disease severity depends upon the mutation type and their location. Females generally have null mutations. There is complete loss of function, so they can present with a severe anemia. While males usually carry partial loss of function with the missense mutation, so they have slightly milder form as compared to the females. While clinical presentation, males typically present with the symptoms of symptoms from adolescent and adulthood, and the females usually are less severely affected, then tend to develop features of mild in the mid and late adulthood that is severe. And anemia can be microcytic, normocytic, or macrocytic, and hypochromic anemia. And the fatigue, pallor, and exertional tolerance are the common presenting feature. And these features of ineffective erythropoiesis because of accumulation of ring sideroblast in the bone marrow, and features of iron overload even without transfusion can occur, which presents with a high ferritin and high serum iron concentration and high transferrin saturation. And mild to moderate is splenomegaly can be seen, and occasionally hepatomegaly can be seen because of iron accumulation and liver dysfunction. And sometimes extramedullary hematopoiesis also takes place in the spleen and can take place in the liver. So the hepatosplenomegaly can be present in these patients. Then how to approach a patient with sideroblastic anemia? First of all, when we have to rule out the benign causes, the acquired causes, that is zinc toxicity, lead toxicity, copper deficiency, ATT, or any alcohol based on history finding. And then bone marrow dysplasia should be ruled out to rule out the other acquired causes which are malignancy associated. Then if these are if we rule out these, then suspicion of congenital sideroblastic anemia is there. Then it can be syndromic or it can be non-syndromic. The syndromic form, it can be X-linked. The X-linked sideroblastic anemia can be with syndromic, it can be associated with X-linked sideroblastic anemia with ataxia, which is caused by ABCB7 gene mutation, and it can be associated with myopathy and lactic acidosis, which is caused by NDF1 FB11 gene. And it can be maternally inherited, that is Pearson-Marrow pancreas syndrome, which can occur along with features of pancreatitis. And these patients are usually sensitive for thiamine. They can be called, it is also called thiamine sensitive sideroblastic anemia. And it can further occur with myopathy and lactic acidosis, which is not associated with ATP6 gene. And it can be associated with autosomal recessive syndromic form, which are TRMA gene, with TRMA gene, and other one is a SFID gene, which presents with a fever and B cell immunodeficiency, and with ferrochelatase gene, that is FET gene mutation, which present along with the patients in patient with it's protein protoporphyria, and in patient with Malasa gene, which Malasa gene mutation, myopathy and lactic acidosis, which can occur with other gene mutation, which are PUS1, LARS2, and YARS2. While non-syndromic form can be X-linked, which our patient has LAS2 gene mutation, and other autosomal recessive form like DG, LS, DGR, RLX 5, HASP9, and HSCB, and SLC 25A38. How this case is different in our patient present this patient generally sideroblastic anemia present with either in childhood or early adolescent age group, but in our patient presented with late adulthood, and it presented with pancytopenia with massive splenomegaly. And this massive splenomegaly, what we could investigate that we because either liver uh, because of chronic liver disease which leads to the massive splenomegaly, or the extramedullary hematopoiesis which could have lead to the massive splenomegaly. But for unfortunately we could not work up further based that T2 star MRI was advised to the patient, but it was not done by them, and he lost to follow up. And also delayed diagnosis that led to the chronic liver disease and features of hypersplenism that led to the pancytopenia in our patient. So I'll close there with
Thank you so much. A very interesting case. Raghuveer, anybody is going to discuss this case? So
Yes.
one of the questions I had, I don't know whether there are any questions there. So we are saying it is syndromic,
Non-syndromic.
not
non-syndromic,
syndromic, but it's a
non-syndromic
congenital
X-linked
sideroblastic
sideroblastic.
anemia.
Yes,
But historically, you've seen that you've given pyridoxine,
yes,
and pyridoxine, there seemed to have been a response.
yes.
Yes.
So how do you explain the response to pyridoxine in a congenital sideroblastic anemia?
Sir, actually, the pyridoxine is the coenzyme in the pyridoxal phosphate is the coenzyme in the respiratory chain, which is one of the mutation leading to this defect in pyridoxal phosphate in incorporation in the heme synthesis. So we given pyridoxine thinking that that could be the point where there is a defect which responded luckily patient responded to this.
Okay.
So
And
just to add
yeah.
it, sir. So this X-linked sideroblastic anemia, it has variable sensitivity to pyridoxine. So if you see, some of the patients, they will be responding beautifully, like our patient who presented with a hemoglobin of a 5, and then he achieved a hemoglobin of 12.6 or 13. So some patients will respond very beautifully, and some will have, a mild or moderate type of response, but they will be responsive because the defect itself, the mutation itself, leads to decreased binding of pyridoxine to the site, and probably supplementing with a higher dose of pyridoxine bypasses that block and leads to response in these patients.
So the other question would be, unfortunately, this patient sort of left medication and has come back with similar symptoms.
Yes.
Now, if you try pyridoxine again, will it respond? And my main question would be, if there is no response now to pyridoxine, what would be your approach to this patient? Would splenectomy work? Would, of course, allogenic transplant would be the ultimate solution? What are your thoughts?
Sir,
So
actually, sir, I have gone through the literature, but there was I don't think there is any chance for a transplant or any. I don't get any data on that.
so
But
keeping in view, Dr. Rajkumar, keeping in view that patient has responded very beautifully to the initial exposure of pyridoxine. So especially we have to see that the doses of pyridoxine what we are giving is adequate, and the recommended dosage is somewhere between 50 to 200, and maybe 75 to 150, something like that. So what we usually support is pyridoxine. Mostly we give 40 milligram or something. Like we have a tendency to give in the patient who are getting anti-tubercular drugs, so Benadone half tablet or 20 milligrams, something like that. So here we have to see that we have to give adequate doses, and once the patient achieves that maximum hemoglobin, like in this patient, we have to taper off the doses and try to maintain the dose at which patient is maintaining the hemoglobin. Like if he is maintaining at 20 milligram or 40 milligram, whatever, that has to be continued. As this patient has left the treatment, again it has shown that there is decline in hemoglobin, and most likely he will respond to again supplementation. But we have to keep in mind that this drug in long term, especially if you are using above 100 milligram, can lead to peripheral neuropathy. So that we have to keep in mind, and we have to maintain the low minimum doses. Regarding transplants, are in this patient, as the patient has a very good outcome, he has the disease since 2 years of age, but it was so mild, and mostly X-linked sideroblastic anemia, they are mild to moderate only. He has never required transfusion. Probably this transfusion which he required at the time of presentation and the last 4 months before presentation was probably maybe because of the hypersplenism or some other secondary infection, like we also thought of parvo, probably leading to this sudden drop in hemoglobin, but it was not positive. There may be some reasons for that, but otherwise he has done excellently. Iron chelation is very important in this case, so iron chelation must be given, because this is iron overload status, just like thalassemia intermedia. So here iron chelation and off and on transfusion with pyridoxine support will lead to improvement in most of the cases. In contrast to this, the second most common again mutation, which is autosomal recessive, is like, see, he mentioned SLC25A38, which is a mitochondrial carrier protein. Here the patients are symptomatic, severely symptomatic since very early age group, maybe 2 months or 4 months itself, and they are transfusion dependent like thalassemia major. So these are the conditions where transplant has a definitely role. There the only curative option is transplant. We cannot go ahead with only transfusion or pyridoxine in that case. So this is my submission.
So,
Sure.
adding on to the question, sir, because the patient's splenomegaly has reduced significantly, sir, to almost 3 centimeter. So there is a bright chance that he had extramedullary hematopoiesis rather than hypersplenism. So in that cases, I don't think splenectomy would have been helpful if he didn't respond to second course of pyridoxine. Then transplant would be the only options.
Okay, sure. Are there any questions from any of the panelists, participants? Any questions you want to ask on either of the two cases, both the CML case and this? Okay, I do not see any questions. So thank you so much, Dr. Verma, Aritra, Rajkumar, and Raghuveer. I will now hand it over back to the Intas team.
Thank you so much, sir. So, as we conclude the 15th episode of Blood the Life Savior, I, Deeksha Gehlot, on behalf of Intas Pharmaceuticals, wish to offer our most profound thanks to the esteemed team from King George Medical University, Lucknow. Our sincere appreciation goes to Dr. Aritra Saha and Dr. Rajkumar Maurya for their excellent case presentations. We also extend a special thanks to Dr. P. Raghuveer for discussion and moderation of the cases. To Dr. S. P. Verma, Professor and Head, thank you for your insightful summary for steering today's session so effectively. We also remain deeply grateful to our course directors, Dr. Biju George and Dr. M. Joseph John, for their unwavering guidance in shaping this initiative. Finally, thank you to our participants for joining this learning journey. We look forward to seeing you at our next session. Thank you and have a wonderful evening. Thank you, sir.
Thank you very much. Thank you, Biju sir, for your kind presence, and thanks to all my teammates for this nice presentation. Thank you.
Thank
Intas
you.
Thank you, sir.
Thank you.
Support, you can end the session.
Sure, ma'am.